String halt is a gait abnormality characterized by exaggerated flexion of one or both hind limbs. Several forms have been described. In the U.S., the most common form is conventional or classic string halt. Some types of conventional string halt are associated with trauma to the dorsal proximal metatarsal region. In other cases, a peripheral neuropathy associated with neurologic disease may be present. But the majority of conventional string halt cases have no known initiating factors. With the exception of the string halt gait, many horses, like this horse, have an unremarkable history and clinical examination. Surgical treatment is generally indicated for cases of string halt associated with dorsal metatarsal trauma or horses with string halt of unknown etiology. A number of horses improve after surgery, but some horses show no improvement. Unfortunately, the likelihood of improvement after surgery is difficult to predict preoperatively. The distal incision is made directly over the lateral digital extensor tendon, just proximal to its junction with the long digital extensor tendon. The tendon is elevated to the level of the incision. Pulling on the isolated lateral digital extensor tendon in the distal incision can be used as a guide to the location of the lateral digital extensor. The proximal incision is then made directly over the lateral digital extensor, starting at the muscle tendon junction and extending proximally. After incising the skin, the subcutaneous tissue and crural fascia are incised to expose the lateral digital extensor. Blunt dissection and large carmel forceps are used to elevate the muscle to the level of the incision. A small amount of sharp and blunt dissection is also used to free restricting tissue from the muscle tendon unit. The lateral digital extensor tendon is excised in the distal incision, and the entire tendon is then pulled through the proximal incision. This is the most difficult aspect of the procedure and is best accomplished by placing large forceps underneath the lateral digital extensor and pulling proximal and lateral. The muscle is then severed into the proximal portion of the incision so that at least 2 centimeters of muscle is removed. If necessary, the remaining muscle stump is cauterized or oversewn with absorbable suture material. The distal incision requires closure of the skin only. The proximal incision is closed in 2 layers, the crural fascia and the skin. Tight, accurate apposition of the fascia is important to decrease seroma formation. Postoperative management consists of bandaging and stall rest. Improvement after surgery can occur in the immediate postoperative period or days to months following surgery. Some horses do not improve. This horse showed no improvement in the initial postoperative period, but then gradually improved in the following 3 weeks and is shown here 60 days following surgery.